Nothing will change. Nothing will change. So I was saying good evening everyone. I was just saying yes, it's come. I'm sorry. I switched it off while I was talking to the backend team. Okay. It will come. Just wait for a minute. Just wait for a minute. I brought this upon myself, I know. I started speaking without video. Now it's audible. Now it's audible. Now it's audible. Now, okay, perfect. We are good to go. Yeah, so I was saying last week should be a no-brainer week. You don't analyze, you don't think anything, you don't think I'm going to get selected, you don't think I'm not going to get selected. You just make sure you get up, spend 6 to 8 hours with the book, sleep well at night, have a good food, try to be cheerful, and just reach the exam with a level of sanity that is going to make sure that you use your brain in the exam for which you have trained yourself in the last 1.5 years. All right. So with this, we are going to start with DVT based revision for anesthesia. And we know anesthesia as a subject is one of the easier subjects because whatever I teach you is what is asked in the exam. And we discuss a lot of common and very interesting and very important topics in anesthesia that is given in DVT. So this test is based on what we discuss in DVT so that whatever last minute revision program you have, you do that, you do some tests and you feel happy that, okay, I have done the revision, I've used some of that revision material on the test and this is just a confidence booster for you. If you know all the questions in the, all the answers to the questions that I've asked you, that is the best. If you have missed few, it doesn't really matter. All right. Just a second, all right? Just a second. What is happening? Am I audible to everyone? Am I audible to everyone? I know? So just give me a thumbs up and I'm going to keep it quick, not going to make too much gyan for everything. I just want to say at the start to all of you that everything that you are feeling right now, everything that you are going through right now, everything is normal and you are going through all of this because you care, because this exam is important for you, because you have put a lot of hard work and that is why you're having all these emotions. So don't feel you are the only one. Don't feel that the topper sitting somewhere in India knows that he's the topper. He will only know or she will only know when they become the topper. Right now, even the topper is thinking the same thing. Oh my God, this is not going to happen. Oh my God, I don't think I'm going to make it. Oh my God, I don't remember anything. Right? So all of these things are going. Yeah. See, don't look at fake news. If it has to get postponed, it will get postponed. You and me cannot do anything about it. You just focus on reaching the exam center. If it gets postponed, you will know it on the day of exam as well. All right. So all these fake news, everything coming, avoid social media at all. Do not talk to anyone. Just talk to your friends and your family and try to get a lot of sleep. That is the best thing that you can do in the last 1 week. Just try to relax your brain. Just try to, you have seen, right? All the athletes before they go for their matches, the big matches, they relax a lot. They they warm up their muscles, right? So their muscles are their organs which they need for their matches. So for you, for this exam, the biggest muscle that you have to use is your brain. So you have to relax the brain right now so that it is able to work logically in the exam. All right. So with this, like I said, Shrutika, there is no adequate or inadequate score in this test or any test till NEET. Just make sure you reach the exam. That's it. Reach the exam. All right. So let's start with the discussion. I'm going to read out the question. You can answer in the comments. You can give a small justification in the comments for that same answer. And then we will see whether the justification is correct or whether we have missed the point. So question number 1 is a 41-year-old man that has been induced for a laparoscopic cholecystectomy with fentanyl 100 mics, propofol 200 milligram, atracurium 40 milligram. On direct laryngoscopy, it is not possible to visualize the uvula. No vocal cords are seen. That is on direct laryngoscopy. The patient is oxygenated with 100% oxygen. Reposition. Further attempts at direct laryngoscopy are made with no improvements in the view. What is the next step in the management? So this question belongs to which chapter that we discuss in anesthesia? Let's take it step by step. Which chapter? This belongs to pre-op assessment. In pre-op assessment, this belongs to difficult airway algorithm. And in difficult airway algorithm, you have 4 plans. Plan A, B, C, D. So can you tell me what are these plans? Plan A, B, C, and D. What are these plans? Plan A, B, C, and D. What are these plans? First plan is what you want for yourself: laryngoscopy and intubation. Give the exam, get a good rank, take a PG seat, be happy. So for an anesthetist, he wants to go and just make sure that they intubate, conduct the case, come back. Laryngoscopy and intubation. But if you fail multiple times in it, then the next option is oxygenation using a SAD, because that is the next best device that you have. Okay, next best device that you have. If you fail in SAD insertion as well, then what do you do? If you fail in SAD insertion as well, then what do you do? What is your next step? Not is your next step. So you tried multiple attempts of laryngoscopy, failed. You tried multiple attempts at SAD insertion, you failed. What will you do now? What will you do now? Yes, you will give a final attempt at face mask ventilation. Final attempt at face mask ventilation. And finally, if you are not able to even achieve an airway, then you do emergency front of neck access, that is cricothyroidotomy. So this question belongs to difficult airway algorithm, from which we get lot of questions. We tried direct laryngoscopy multiple times, not able to visualize the vocal cord, and then no improvement in the view. Next would be one further attempt at laryngoscopy with the same blade and technique. Of course not. One further attempt with a bougie. No. Abandon and insert LMA. Sounds about right. Abandon and establish an airway using emergency cannula. Will you do that? You're not able to intubate. You will immediately put a front of neck access. No. So the correct answer to this question is abandon laryngoscopy and insert laryngeal mask airway. Insert laryngeal mask airway. All right. Very good. Question number 2. A 68-year-old male with a history of hypertension, coronary artery disease is undergoing hip replacement under general anesthesia. 30 minutes into the procedure, he suddenly develops hypotension, tachycardia, decreased DTCO2. Which of the following is the most likely diagnosis? First of all, what is the chapter to which this question belongs? What is the chapter to which this question belongs? Okay, why not option B? Because bougie helps you. Bougie is like a airway manipulating tool. If you are not able to visualize vocal cords at all, then how will you insert bougie? Bougie is simply a fine conduit that you put, through which you can put the tube, right? So if you cannot visualize the vocal cord at all, then there is no use of you putting bougie. Where will that bougie go? If you are not able to visualize vocal cord, where will you put it? So you need to change the technique. All right. So this question belongs to, this is very obvious. This is, is it? No, chalo, let's, but it actually belongs to complications in anesthesia. Complications. A complication that can very easily be diagnosed by Sudden and abrupt fall of EtCO2. This is seen in which condition? Sudden and abrupt fall of EtCO2. Seen in which condition? Seen in which condition? You are doing a hypertension, coronary artery disease, hip replacement, sudden decrease, hypotension, tachycardia. What does this tell you? Yes. Can it be anaphylaxis? Can it be anaphylaxis? Can it be anaphylaxis? Yes, it can be. But in anaphylaxis, you will get a bronchospastic picture, that is a shark fin appearance on capno. Shark fin. Can it be myocardial infarction? Can it be myocardial infarction? It would not be sudden. There would not be suddenness. If there is myocardial infarction, you will see a gradual decrease in EtCO2, not sudden. So this cannot be. Venous air embolism. Yes. Suddenly a large portion of lung is now getting ventilated but not getting perfused. Is it possible during THR? Yes, it's a long bone surgery. There is a lot of reaming in femur which can lead to venous air embolism. Can it be malignant hyperthermia? Tell me what would be your point in the question that will tell you it's MH. Can it be seen in a patient who is hypertension, coronary artery disease? Yes. Can it be seen in renal hip replacement surgery? Yes. Can it be seen after 30 minutes? Unlikely, but let's say yes. But will it present with hypotension, tachycardia and decreased EtCO2? Will it present with hypotension, tachycardia? No. This will present with sudden and abrupt rise of EtCO2. Sudden and abrupt rise of EtCO2. So MH will be exactly opposite. It will be sudden and abrupt rise of EtCO2. Okay. Somebody asked, sir, this is a femur case. It's a THR. So it should be fat embolism and not air embolism. Very good. You are brilliant. You have made the right differential. Is fat embolism the option? Do you see fat embolism as the option? Is there fat embolism as the option? No, na. So if it is not in the option, then how it can be the right answer to this question? I can give you 5 more differentials of what is happening with the patient. But does it matter to us? Does it matter to us? No. We are here to solve the question, not try to become a clinician. Remember, this is an exam where they ask you a question, give you 4 options, tell you to pick the best option. So just look at the best option and try to answer that. Do not try to become a clinician in the exam and try to poke holes in what the examiner has done wrong. Questions are not going to be always the way you want them to be, but the way the setter, the examiner wants it to be. Okay, in case of esophageal intubation, there is gradual decrease of EtCO2, small dwindling waveforms that will go to 0. This is esophageal intubation. This is esophageal intubation. All right. Question number 3. 70-year-old coronary artery bypass grafting under GA. During the procedure, capnography waveform changes from normal shape to one with prolonged expiratory phase and a raised baseline as shown in the image. Which of the following conditions is most consistent with this capnography pattern? Which of the following conditions is most consistent without looking at the option? Without looking at the option, what do you think is happening? Without looking at the option, what do you think is the happening? Prolonged expiratory phase with a raised baseline. What does this tell you? What has this happened? There is prolonged expiratory phase. That means what? Very good. This is shark fin appearance, which tells us that there is bronchospasm. What does this tell you? Raised baseline. What does this tell you? Raised baseline. Is there any significance of raised baseline? Is there any significance of raised baseline here? Yes, this indicates rebreathing of CO2. Graph not touching the baseline. Rebreathing of CO2. Graph not touching the baseline. Now look at this. Acute pulmonary edema. Will it cause this capnographic waveform? No. Emphysema. Will it cause? No. Pulmonary embolism. Will it cause? No. But acute bronchospasm due to any condition. Will it cause this? Yes. Acute bronchospasm will cause this clinical picture. Very good. है ना? So this information that there is raised baseline, does it have any implication on the question? No, but it is just given to confuse you. You might look at that raised baseline only and you start thinking in terms of exhaustion of CO2 absorber, and you might think, अरे यार ये तो बड़ा अजीब question है, and you might miss the main point that there is a shark fin appearance. All right. Question number 4. Local anesthetics are weak bases and their onset of action can be influenced by. Local anesthetics are weak bases and their onset of action can be influenced by. So again, this is question from local anesthetic mechanism of action. LA mechanism of action. This is a question from local anesthetic mechanism of action. So they are weak bases. So if you increase tissue acidity, decrease tissue acidity, enhance plasma protein binding, and increase alkalinity of the solution, what is going to affect the onset of action? What have we discussed about the onset of action? For this, we have to understand the mechanism of action of local anesthetics. Mechanism of action of local anesthetics. So can anybody tell me what is the mechanism of action of local anesthetics? Local anesthetics are sodium channel blockers. They are sodium channel blockers, isn't it? They block the sodium channels. Can you tell me the site of action? Can you tell me the site of action? Can you tell me the site of action? Yes, it is intracellular surface of sodium channel. Intracellular surface, also called as inactivation gate. Also called as inactivation gate. Intracellular surface of sodium channel. So tell me, for the onset of action, in which form do you need the local anesthetic to be? For the onset of action. You need the local anesthetic to be in unionized form, because it is the unionized form that is going to enter inside the cell, which is then responsible for the onset of action. And all local anesthetics are weak bases. All local anesthetics are weak bases. And we know a weak base is unionized in a basic medium. Unionized in a basic medium. So if you want to increase the onset of action, then you make the medium basic. Then you make the medium basic, isn't it? If you want to increase the onset of action, faster onset, you make the medium basic. So increasing tissue acidity, no. That is why very typically in an abscess cavity, if you try to inject a local anesthetic, there will be no action. Therefore, abscesses, drainage of abscesses can never be done under local anesthesia. You always give some form of sedation like ketamine, where there is a combination of analgesia and anesthesia so that the person doesn't experience pain. If you infiltrate around an abscess cavity, there will be no action. Okay. Decreasing tissue acidity. So now think, is it possible to decrease the tissue acidity? I know a lot of you people are thinking, why not option B? But tell me, would you inject soda bicarb in the tissues where you have to use local anesthetic? Does it make sense to you? You are wanting the onset of action to be faster. Isn't it easy to increase the alkalinity of the solution there where the local anesthetic is present, where the form will get unionized more? So this is possible, this is not possible. I told you the exam will give you questions where the options might not be the same as you want them to be. There has to be a certain degree of diabolicality, but you look at which is the best possible option. The best possible answer for this particular question is going to be increasing the alkalinity of the solution, which we have discussed many times, called as carbonization of the drug of local anesthetic, which is done by carbonization of local anesthetic, which is done by adding soda bicarb to the solution of local anesthetic. So that is the reason the answer is going to be D. All right. Which of the following approaches to brachial plexus block involves deposition of local anesthetic around brachial plexus, typically near subclavian artery, and is commonly used for forearm surgery? Very simple, straightforward question. Very simple, straightforward question. Very simple, straightforward question. Around subclavian artery, supraclavicular approach. Supraclavicular approach, which is most common used approach of brachial plexus block. This is most common used approach to brachial plexus block. What is the most specific complication? Most specific complication of this approach? What is the most specific complication of this approach? Yes, it is pneumothorax. The most specific complication is pneumothorax, while the most common is yet phrenic nerve palsy, which is also the most common complication of interscalene approach of, yes, nothing spared, most common complication, most specific complication pneumothorax, most common is still phrenic nerve palsy. Question number 6. A young man is eating in a seafood restaurant. Okay. Suddenly starts to choke on his food. Okay. Becomes anxious and agitated. Okay. Can't produce any vocal sounds. Okay. You attend to the victim, start assessing the situation when he collapses on the floor of the restaurant. Okay. What is the next step that you will do? Tell me, what condition is this? Describe me this condition first. Describe me this condition first. What is happening here? This is a condition which we commonly encounter, which is called as choking or foreign body obstruction. We call it choking or foreign body obstruction, isn't it? Now there are two types of choking or foreign body obstruction. Can you tell me what are the two types? Either it can be partial or it can be complete. How do you differentiate between the two? Sound. If the patient can produce any sound, partial. If the patient cannot produce any sound or gives universal choking sound, it is incomplete, complete. This refer to ENT surgeon. refer to ENT surgeon. This you treat. Now you'll be getting two conditions here. Patient is responsive or the patient is unresponsive. If the patient is responsive, what will you do? Heimlich's maneuver. If the patient is unresponsive, what will you do? CPR. What will you do? CPR. This is the algorithm for choking. This is the algorithm for choking. So what is happening here? He becomes anxious, agitated, can't produce sound. So complete choking. You assess, but by the time you are assessing, he collapses on the floor. Next step would be CPR. Next step would be CPR. But in which condition we will do chest Heimlich's? When the patient is adult responsive. When will you do chest compression and back blows? When less than 1 year child responsive. And when will you do blind finger sweep to remove the food particle? Never. Never. That is the most important part, Shrutika, that if your patient is unresponsive with foreign body obstruction, that means that foreign body obstruction must have caused something, mostly hypoxia, that has caused cardiac arrest. Now it is important for you to write to save the heart rather than looking at the foreign body, because all the time that you put in saving the removing the foreign body, the patient have no circulation. If there is no circulation, the heart and brain will start dying immediately. So what is the point of you trying to take the foreign body out if the heart is not working? So that is what we do in CPR, right? We first try to manage the stoppage of the heart, and then we start looking at conditions that has caused that heart to stop working, and then start treating them accordingly, right? So it is very, very important for you to remember that in cardiac arrest, your management has to be always CPR. Okay? Okay, question number 7. You are in a dental clinic. You have a pediatric dental case. You need to provide conscious sedation to the child for dental extraction. Which of the following cylinders will you ask? Forget about the cylinder. Tell me, in a pediatric dental clinic, what do you use? Okay, sorry, I misread it. Thank you, Manisha. Yes, no. Why would you want to do Heimlich's for partial? Partial, that means the patient can breathe, right? So it's not a medical emergency. If the patient can breathe, is it a medical emergency? No. So then why would you give thrust to the patient and try to lodge it out? Send it to the ENT surgeon. They will put the scope, take the foreign body out. I know. Yes, very good. Mehak has answered it absolutely correctly. If it is not an emergency, then you will not simply give Heimlich's to the patient, hai na? Yes, very good. So you use Entonox, which is a mixture of 50% oxygen and 50% nitrous oxide in a cylinder. 50% oxygen and 50% nitrous oxide in a cylinder, which is blue body with blue and white shoulder, which looks like this. If it was oxygen, it would look like this. If it was nitrous oxide, it would look like this. Okay? This is Entonox. This is Entonox. Blue body with blue and white shoulder. Question number 8. Which of the following is the most reliable method of monitoring depth of anesthesia? Pretty straightforward question. Most reliable method of monitoring depth of anesthesia. Is it important? If you can't identify, I have not taught you, then does it matter what it is? It is just an option that you rule out. Okay? Hima? Yes. Straightforward answer. Bispectral index. Most reliable method for monitoring depth of anesthesia is bispectral index BIS, which is a frontal processed EEG. Frontal processed EEG. All right. Question number 9. A 35-year-old female undergoing cesarean section under spinal anesthesia complains of severe headache post-operatively, which is exacerbated by sitting up and relieved by lying flat. What is the most appropriate initial management of this complication? Most appropriate initial management of this complication. So first tell me the complication and then tell me the most appropriate initial management. First tell me the complication and then tell me the most appropriate initial management. Very good. The complication is post-dural puncture headache, PDPH, which develops after a dural tap because of leak of CSF, and the first line management is always conservative. So if somebody is having headache after a spinal anesthesia, will you give them intravenous morphine? Too much ho gaya na? CT? No. Epidural blood patch directly? No. Simply try to increase CSF production by giving oral caffeine. Increase CSF production by giving oral caffeine. That is easier. Okay. Last line. Perfect management, best management, treatment of choice, epidural blood patch. Okay. Question number 10. During a general anesthesia procedure, a 45-year-old male with no significant medical history suddenly develops bronchospasm, hypotension, generalized urticaria. Which of the following medication is most likely to have caused this reaction? Okay, facts to know. I'm going to ignore your question because what you are doing is you are trying to get the postgraduate knowledge to the undergraduate exam. Okay. So try to remember what is not relevant should not be looked upon in the last week before the exam. So forget about if you know sphenopalatine ganglion block, forget about it. All right. Just remember first line conservative management, best management, epidural blood patch. Anything apart from that is not scientifically substantiated and therefore doesn't find mention in the textbook. We follow textbook and not articles. All right. Yes, very good. This is anaphylaxis, and the most common etiology of anaphylaxis is antibiotics, followed by muscle relaxants, followed by chlorhexidine. In muscle relaxants, most implicated is rock, followed by scoline, followed by atra. Rock, scoline, atra. So the correct answer is rocuronium. Okay. Very good. So it was not an easy question. You think it was easy? I have made three layers to this question. First, I have given you a clinical condition, so you need to diagnose that. Then you need to know what are the etiology of that clinical condition, and then in that etiology, what is the order. So it's not an easy question. So don't think it's an easy question that you missed. Even if you have diagnosed the condition and you remember the order, that is more than enough. Okay. Bronchospasm, hypotension, generalized urticaria. Don't you think it's a very clear picture of anaphylaxis? How is wooden chest syndrome here? Wooden chest syndrome is the patient is not able to breathe in, which is seen after a high dose of fentanyl. Patient will not be able to breathe. Will there be hypotension? Will there be generalized urticaria? No. So how can you relate an entire spectrum with just one finding, that is wooden chest? The entire spectrum points towards anaphylaxis. So you go and look at the causes of anaphylaxis. Okay. Yeah, that is fine. It doesn't have to release histamine to cause anaphylaxis, right? I'm not talking about causing histamine release, causing these things. It is very simple. It is causing anaphylactic reaction. The mast cells in your body are releasing histamine. Not necessarily that the histamine is released by rocuronium. Rocuronium acts as the antigen against which there is an anaphylactic response. That is going to cause massive release of histamine in the body, and you see features of anaphylaxis. Okay. Yes, I know. That is an answer to the question, which of the following agents in anesthesia release histamine? So the answers would be thiopentone, atracurium, scoline, mivacurium, morphine, meperidine. Okay? That is answer to the question who release histamine. This is not the question on histamine release. Question number 11. Which of the following is the best combination of nerve, muscle and pattern of stimulation used for the technique shown? I don't know for what you should mark fentanyl, because this question is not related to fentanyl. This is simple anaphylaxis, intraoperative anaphylaxis. The etiology is antibiotics are most responsible, followed by muscle relaxants, followed by scoline, in fact, followed by chlorhexidine. And actually, there is only one muscle relaxant in the option. The anaphylaxis is seen intraoperatively, and therefore the answer goes rocuronium. It's as simple as that. All right. So this is neuromuscular monitoring, and we know in neuromuscular monitoring the most common nerve involved is ulnar nerve. Most common muscle is adductor pollicis, and the most common pattern is TOF. If you see, all three answers are given in the image itself. So a question cannot get easier than this, है ना? देखो ध्यान से देखोगे तो तीनों चीजें दे दी है, अल्नार नर्व भी दे दिया हूँ, adductor pollicis भी दे दिया हूँ. देखो उसमें इमेज में लिखा हुआ है TOF 95%. So I have given you everything in the question itself, है ना? Question number 12. A COPD patient is admitted to ICU and is on oxygen therapy with a face mask with 2 liters of oxygen. He was found to be hypoventilating and his PCO2 on blood gas shows 65 mmHg. What is the best strategy for this patient? What is the best strategy for this patient? Ruma F? Is there an option F? The options are only A, B, C, D. So, most of you are saying D, which you have to justify, but some of you are saying option C. Who is that? Rishita is saying option C. So, you have to justify that as well, Rishita. You have to tell me why do you think it is C? Acute hypercapnic exacerbation of COPD. Very good. NIV, COPD exacerbation. Yes. Respiratory failure type 2. CO2 accumulation. You only want to get that CO2 out. It's accumulation of CO2 that is the problem. So what you will do? You will start BiPAP. Very good. Very good. If the problem is accumulation of CO2, then will the problem really be okay if you simply start O2? No, doesn't make sense. The problem is that the patient is accumulating CO2. In a COPD patient who are oxygen dependent breathing, if you give too much of oxygen, their respiratory rate is going to decrease further. and so there will be more CO2 accumulation. You don't want that. You actually want effective exhalation of CO2, which can very well be done by starting a BiPAP, which is bi-level positive airway pressure. Okay, very good. Question number 13. A 60-year-old patient with severe aortic stenosis requires induction for urgent surgery. Which intravenous agent would be most appropriate? Your answers. Which intravenous agent would be most appropriate? When to mark option B, decrease FiO2. If suppose they have given an ABG where they have shown you that the PaO2, which is the arterial concentration of oxygen, is too high, say 150, 200, you want to keep it between 75 to 100, that is normal. In COPD patients, even 70 is okay. So we keep usually a target between 75 to 100. Suppose if it is 150, then you will obviously decrease FiO2, but you have to give BiPAP. You have to give BiPAP. In BiPAP, the amount of oxygen that you are going to use would be lesser. Yes, straightforward question. Etomidate cardiostable. Aortic stenosis needs stable hemodynamics. Stable hemodynamics. Alright. So, etomidate. Which of the following is an inhaled anesthetic agent that can be used for both induction and endotracheal intubation? Which of the following inhaled anesthetic agent can be used for induction and endotracheal intubation? आंसर विथ योर जस्टिफिकेशन है ना, आंसर भी चाहिए मुझे, जस्टिफिकेशन भी चाहिए. Which of the following inhaled anesthetic agent can be used for both induction and endotracheal intubation? अफलातून जस्टिफाई करो आंसर को, है ना. Just don't just give me an answer. Use little bit of words with it. So when you talk about using an inhaled anesthetic agent for induction, then you want it to be sweet smelling. And which are the agents, inhaled anesthetic agents under anesthesia, which are sweet smelling? Which are the inhaled anesthetic agents which are sweet smelling? Both Sevo and Halo. Now you would ask, sir, जब दोनों है तो मैं Halo क्यों नहीं pick करूं? Because for induction of anesthesia, you want rapid onset and Sevo is fast while Halo is slow. That is from the blood gas partition coefficient. We know halothane is much more slower. It is more soluble in blood, and therefore Sevo is the choice of agent for induction and not halothane. You can use both for induction and endotracheal intubation, but you will use only sevoflurane, yes, because halothane is slow. So slower agents should not be used for induction of anesthesia. Once again, the answer to this question is the best possible answer and not what you think it should be. I have very purposefully, a week before the exam, given you such diabolical options so that you get into this mindset that in the exam you will not always get a question where the answer would be very straightforward and you would feel कि हाँ ये तो perfect है. Sometimes you need to understand the best possible answer is different from what you feel as the potential answers. तो थोड़ा ये deliberate attempt है मेरा. Don't feel bad. Don't feel bad if you are not able to do these things and you make a mistake. That is precisely the reason why I have done this. So that a week before the exam, you get into this mindset that I have to be open-minded. I have to try to find the best answer in the exam and not just simply put your answer कि नहीं जो मैंने सोचा है वही सही है. Don't be adamant in the exam. You don't have to fight with the examiner. You have to learn to get your correct answer and just move from there. ठीक है, लड़ो मत एग्जाम में. डोंट बी फाइट विद द एग्जामिनर. अरे गधा है, उसको आता नहीं है, he has written it wrong, he has given a wrong question. Even if he has given a wrong question, you have to choose the best answer out of it and mark and move on. ठीक है, all right. Question number 15. Which of the following is the correct combination of oxygen delivery devices which can deliver fixed FiO2, highest FiO2 respectively? ये साला क्वेश्चन इतनी बार आता है ना, मैंने सोचा मैं इसको मिक्स करके डाल देता हूं, झंझट ही खत्म करेंगे. एवरी टाइम एवरीबडी आस्क्स मी, सर कौन सा हाईएस्ट है, कौन सा फिक्स्ड है, कौन सा हाईएस्ट है, कौन सा फिक्स्ड है, कौन सा हाईएस्ट है, कौन सा फिक्स्ड है. तो कौन सा हाईएस्ट है, कौन सा हाईएस्ट है, एनआरबीएम. कौन सा फिक्स्ड है, वेंचुरी. ठीक है, समझ गए, याद रखो, फिक्स्ड, वेंचुरी, हाईएस्ट, एनआरबीएम. किसी को कोई शंका, किसी को कोई दिक्कत? आई होप नॉट. अच्छे बच्चों, योर प्रिपरेशन इज गोइंग गुड, आई एम वेरी हैप्पी. ठीक है, pat yourself on the back a lot. What I am telling you, you need to tell yourself in front of the mirror every day. Don't keep saying नहीं होगा, नहीं होगा, नहीं होगा, नहीं होगा. इतने सारे लोग हैं, इतने सारे बच्चे हैं. Doesn't matter how many people are there. Doesn't matter what is the competition. You are not fighting with someone else for a seat. You are simply going to go and pick up your own seat. Don't think कि जो बाजू में बैठा हुआ है वो आपसे आगे निकल जाएगा. Maybe he will get a seat of his choice and you will get a seat of your choice. It's very simple. There's Am I audible now? Visible now? Am I audible and visible now? I don't know why such things happen. अच्छा खासा सब कुछ चल रहा था. Suddenly my entire system just froze. Oh, perfect. So we are back. ठीक है. So which of the following agents is the correct sequence of potency of anesthetic agents? Potency. So potency is MAC. Okay. And onset and offset of action is solubility. And in both we know the order is that CO is less potent than ISO, which is less potent than halo, and CO is less soluble than ISO, which is less soluble than halo. So CO is faster and less potent, and halo is more potent and slower. ठीक है. So whenever you get a question like this, then always first look at CO, ISO, halo. So देखो ये क्या बोल रहा है, sequence of potency. So can isoflurane be more potent than halothane? No. Methoxyflurane more potent than isoflurane, which is more potent than halothane? No. Then nitrous is more potent than halothane? No. Methoxy more potent than halo, more potent than iso, more potent than nitrous. देखो automatically you find the best option. Automatically you find the best option if you remember halo, iso, CO or CO, iso, halo. If you remember that, 99% time you don't need to look ahead. But yes, for completion, if you talk about least potent, then it is nitrous oxide. And if you talk about fastest, then it is xenon. Then it is xenon. ठीक है? हाँ मोहन बोल. ठीक है. Question number 17. Question number 17. A case of head injury with subdural hematoma with high intracranial pressure going for surgical drainage. Which of the following combination of anesthetic agents should be used for induction and maintenance of anesthesia respectively? Induction and maintenance of anesthesia respectively. So it is a case of raised ICP. raised ICP. So tell me which agent causes maximum decrease in ICP? Which agent causes maximum decrease in ICP? Maximum decrease in ICP. Max decrease in ICP. The answer is thiopentone. So ideally, which agent should we use for induction of anesthesia in cases with raised ICP? Thiopentone. Is it given in the option here? Yes. Now tell me what is the action of volatile anesthetic agents on ICP? All volatile anesthetic agents increase ICP. They all increase ICP, isn't it? So should you use volatile anesthetic agents in a case of raised ICP? Ideally, should you use it? No. But if at all you have to use it, then which agent should you use? If at all you have to use it, which agent should you use? SIVO. Why? SIVO has minimum increase in ICP. So it increases, but minimum. But ideally, should you use it? No. So do you have an option where you use only IV agent? Yes. So that is the correlation. That is the correlation, है ना? Ideally तो क्या होना चाहिए? Thiopentone propofol. Thiopentone for induction, propofol for maintenance. वो इसमें ऑप्शन में नहीं है. Propofol, sevoflurane would be the third option if you have to use inhaled anesthetic agent, तो वो नहीं है. Ketamine तो देखो obviously out of question है, but yes, propofol for induction, propofol for maintenance is the best possible answer here. ठीक है, बेस्ट पॉसिबल आंसर हियर. एंड एक्चुअली में हम टीवा इसीलिए देते हैं बिकॉज जहां पे हम इनहेल्ड एनेस्थेटिक एजेंट्स नहीं दे सकते वहां पे हम टीवा देते हैं. ठीक है, अगेन द ऑप्शंस आर नॉट कंड्यूसिव टू व्हाट यू थिंक दे शुड बी एंड दैट इज व्हाई यू नीड टू लुक एट द ऑप्शंस केयरफुली टू अंडरस्टैंड द साइकी ऑफ द एग्जामिनर. ठीक है, रिगार्डिंग सक्सामिथोनियम, it's an antagonist at nicotinic acetylcholine receptors. It should be given in increased doses in patients with DMD. It's a partial agonist at acetylcholine receptor metabolized by acetylcholinesterase. Pretty straightforward question, na? Whenever you think of scoline, what did I tell you? You should always think of, whenever you think of scoline, you should always think of acetylcholine, and we know scoline is a younger brother of acetylcholine. So it is a complete agonist. Acetylcholine is a complete agonist and scoline is a partial agonist which is metabolized by plasma choline esterase. So the correct answer here would be C. Very good, Snigdha. ठीक है, all right. Which of the following is considered to be the most susceptible fiber to local anesthetics? हमेशा का झंझट खत्म करते हैं. Which is the most susceptible to local anesthetic? Most susceptible. Why not D? You tell me why not D? Because it is not metabolized by acetylcholinesterase. Is it metabolized by acetylcholinesterase, Ashish? Why not D? ये तो fact based चीज है that scoline gets metabolized by plasma cholinesterase. That is why not option D. ठीक. देखो ये मजा आया ना. DAC, 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 DAC. Anybody who has seen my session, who knows it, they will always remember the susceptibility of individual nerve fibers to local anesthetic is A, B, C. In A, gamma is most susceptible, followed by delta, followed by alpha, followed by beta. ठीक है, करेक्ट आंसर इज ए गामा. ये इसीलिए किया हूं, एक हफ्ते पहले एग्जाम के हाथ जोड़ के विनती करता हूं, do not get confused, do not get distracted, do not get dispersuaded by anyone. Remember the order is A, B, C. What is the order? A, B, C, A, B, C, A, B, C, A, B, Z. Gamma, delta, alpha, beta, B, and C. Gamma, delta, alpha, beta, B, and C. Gamma, delta, alpha, beta, B, and C. Please. एग्जाम में आएगा प्लीज डोंट गेट कंफ्यूज, नहीं तो मुझे बहुत बुरा लगेगा कि समथिंग विच इज दैट इजी यू आर अननेसेसरली मेकिंग इट डिफिकल्ट. ऑलराइट. Question number 20. Which of the following combination of the conditions is associated with a falsely low reading on pulse oximeter readings? Which of the following combination of conditions is associated with falsely low reading? Will hypotension cause false low reading? Yes. Fetal hemoglobin, carboxyhemoglobin? No. No. Carboxyhemoglobin? No. Dark blue nail polish? Yes. Henna? No. Acrylic fingernail? No. Methemoglobin? Yes. Indocyanine green? Yes. Shivering? Yes. आंसर इज मार्क्ड रॉन्ग. कहां पे बेटा, कौन से वाले का बोल रहे हो, कौन सा करता है? हाइपोक्सिया का भी बता दो सर. यार हाइपोक्सिया तो हम करते ही नहीं ना, हम तो एनेस्थेटिस्ट हैं, हम पेशेंट का ऑक्सीजनेशन बढ़िया रखते हैं. तो हाइपोक्सिया तो आपको फिजियोलॉजी वाले बताएंगे, है ना. जो हम करते नहीं उसके बारे में हम बात करते नहीं. ठीक है. I am only as amazing as you guys. My students are amazing and that is why I am amazing, है ना. So remember, you have to be awesome in the exam. And then only I will say कि हाँ, you are saying right, I am amazing. Very basic questions. Only try to correlate. You have read everything. थोड़ा calm state of mind से जाओगे ना तो ये सारी चीजें समझ में आ जाएंगी. अपने ऊपर दुनिया का भार लेके मत चलो, ठीक है ना. तुम ना तो पहले हो जो पीजी एंट्रेंस देने जा रहे हो, ना तुम आखिरी हो जो उसमें से सीट लेके निकलोगे. पीपल हु गेट द सीट डोंट हैव अ हैलो अराउंड देम. आई डिड पोस्ट ग्रेजुएशन, सो विल यू. मुझे देखो, मुझे लग रहा है कि मैंने पीजी की हुई है, नहीं. आप जाते हो, एग्जाम देते हो, रैंक आती है, सीट लेते हो, आगे बढ़ते हो. इट इज जस्ट अनदर डे, जस्ट अनदर एग्जाम, जस्ट अनदर इवेंट इन योर लाइफ. ट्रस्ट मी, मैरिज इज मच मोर डिफिकल्ट देन नीट पीजी. तो कभी भी ऐसा लगे कि मेरे साथ ही ऐसा क्यों हो रहा है, व्हाई एम आई स्टक लाइक दिस, इट शुड नॉट हैव हैपेंड टू मी. रिमेंबर, व्हेन यू गेट मैरिड यू वोंट हैव एन ऑप्शन ऑफ गोइंग बैक. दैट इज अ परसिस्टेंट एग्जाम इन योर लाइफ. सो टिल दैट टाइम वॉट एवर इज देयर, इट इज ओनली मोमेंटरी. सो जस्ट एंजॉय and relax. All right. In question none, why not option D? You want me to go to question 1? Fetal hemoglobin is normal hemoglobin, isn't it? Fetal hemoglobin is normal hemoglobin. Why not option D? You tell me. आप पेशेंट को इंट्यूबेट नहीं कर पा रहे हो, आप सीधा उसको खोल दोगे? हाँ? Is that how the difficult airway algorithm works? It's an algorithm. You have to follow step by step. Acute trauma, ऐसा कोई नर्व फाइबर थोड़े ना इन्वॉल्व होता है बेटा acute trauma में. आप जो नर्व तोड़ोगे वो तोड़ोगे, है ना. ठीक है. That's it. Fetal hemoglobin is normal hemoglobin. तो नॉर्मल रीडिंग होगी, जो रीडिंग होगी वही दिखेगी, है ना. Absolutely, that should be the attitude. Daycare surgery, propofol, sevoflurane. Remember, propofol, sevoflurane. ठीक है, चलो. All the very best. I will hang up. It is supposed to be a short session. I don't want to prolong it. We have done it for about an hour. 20 questions. If you want, you can go back and see at the video again. It will be uploaded on the YouTube. It will always be there for you. So just go and see it. Okay? ठीक है. कुछ डिस्कस करने का नहीं है. अगर कोई आपको बोलता है कि वो याद करो कि पिन इंडेक्स में कहां पे क्या होता है, नहीं करना है, आपका काम ही नहीं है वो. मैं नहीं देख के बता सकता पिन इंडेक्स की कौन सा सिलेंडर है. ठीक है. क्या बोल रहे हो? सीओपीडी वाले क्वेश्चन में वेन टू मार्क बी, कौन सा था भाई? कौन सा सीओपीडी वाला क्वेश्चन? कौन सा वाला क्वेश्चन? नंबर बता सकते क्या बच्चे? वेन टू मार्क बी, आई टोल्ड यू ना, अगर PaO2 ज्यादा होगा तो मार्क बी कर दो, डिक्रीज कर दो FiO2. सपोज दे गिव यू PaO2 रीडिंग दैट इज मोर देन 100, तो यू टाइट्रेट इट एंड डिक्रीज द FiO2, है ना. कोई नहीं, कर लेगा रेक्सनेट, तू सब हो जाएगा, है ना. चलो, थैंक यू सो मच. आई लव यू ऑल गाइज. आई विल सी यू ऑन द अदर साइड. ऑल द वेरी बेस्ट. स्टे काम. There is no other advice than the last week. Just stay calm, sleep well, eat well, be happy. All right.